Okay, so good morning again, and this morning we're going to dedicate to type 1 diabetes and low carb diets. Is this on? Sorry, just a few. Go now? Okay, thank you. My clicker wasn't working. So my name's Whelan. I'm a pharmacist and I'm also a Credentialed Diabetes Educator. I'm also a person living with type 1 diabetes. So throughout today, I'm going to talk a lot about evidence and science, but I'm also going to talk a little bit about my personal experience as well. Just to outline what we're going to talk about, for those that aren't familiar with type 1, we're just going to quickly define that and also talk about insulin management of type 1 diabetes, why low carb as a question, and we'll have a look at some evidence and some of the outcomes that we commonly measure for people with type 1 diabetes, such as HbA1c, severe hypoglycemia, and diabetic ketoacidosis. So what is type 1 diabetes? Type 1 diabetes is an autoimmune disease. So it's where the immune cells of the body destroy the cells of the pancreas, and these are the cells that make insulin. At this stage, there is no one known cause or way to prevent it, and we still don't have a cure. So type 1 diabetes results in an absolute deficiency of the hormone insulin. And insulin is an important hormone in the body. It has many functions, and one of its major roles is to regulate blood glucose. So in a person without diabetes, blood glucose balance is an automatic function, but people with type 1 diabetes need to inject insulin and manually regulate their own glucose levels. So these days, people can do that a couple of ways. So they can do it with multiple daily injections of insulin through a pen or a syringe, or they can actually wear an insulin pump. We do need to monitor our blood glucose levels regularly in order to manually regulate them. And so, just to share my story in terms of diagnosis and the importance of what insulin does, I was actually diagnosed with type 1 diabetes when I was 22. I was showing classic signs, so tiredness being one of them, and I was actually sleeping up to 16 hours a day and still falling asleep in lectures at uni. I was so thirsty, I was drinking up to 6 litres of water a day, so which meant I was forever on the toilet. And I was probably the only person in the history of university to lose weight eating dining hall food as well. So weight loss was also an issue. So having studied medical science in pharmacy, I did recognise my symptoms and I took myself to the GP and I did ask for a blood test. My blood glucose level came back at 32, so that's almost 7 times normal. Being diagnosed and managed in a primary care setting, so rather than being admitted into hospital, I seem to have bypassed much of the standard education and dietary advice given to people diagnosed with type 1, and that might really influence where I am today. So let's look at insulin management of type 1. Traditionally, we actually used, the mainstay treatment of type 1 diabetes was carbohydrate restriction. So we were able to actually extend the life of people with type 1 diabetes by years. And this was before the discovery of insulin. And it wasn't until the 1920s where Banting and Best discovered insulin and gave the first injection of insulin. And this is when we're able to reintroduce carbohydrates into the diet. And of course, the discovery of insulin is really the only reason I'm sitting here today. I've had type 1 for more than 14 years now, and I certainly wouldn't have survived this long even on a restricted carbohydrate diet without insulin injections. So unfortunately, in the 1980s, came the demonization of fat and the emergence of increased carbohydrate in our diets. Unfortunately, this came without proof of superiority for any population, but people with type 1 diabetes were also recommended to eat this high carbohydrate diet, despite having a chronic condition by which definitively we cannot process carbohydrates. So it's important to understand when we dose insulin that all food that we eat has a requirement for insulin. So insulin is required for amino acids from protein to be utilized in the body. It's also required for us to store fatty acids from fat. But it's actually the carbohydrates that are broken down to glucose in our food that have the biggest requirement of insulin and also the largest impact on our blood glucose levels. So this is why many people with type 1 diabetes, they're actually taught to inject insulin according to the amount of carbohydrate in their meal. And what we do is we teach people to use what we call an insulin to carbohydrate ratio. What that tells us is how many grams of carbohydrate does 1 unit of injected insulin store away for that individual person. So if I'm saying to you that all you have to do is count your carbs in your meal to calculate your insulin dose, then all would be great, right? So there's actually two fundamental problems with this model. Firstly, counting carbohydrates inevitably comes with error. So even packaged foods will be up to 20% incorrect in their labeling. And the higher the carb in the food, the higher the potential error, which translates to error in insulin dosing. And this then creates unpredictable blood glucose results. And the real life experience of this isn't fun. So to illustrate this error, we are taught that a piece of bread has 15 grams of carbohydrate. Have you ever ordered eggs on toast at a cafe and got the same size bread each time? So when we go out, we could get a large slice, a thick slice, a thin slice, different types of bread, a sourdough, multigrain, all sorts of different breads. And to actually equate a piece of bread is really difficult. And so unless you actually carry around a set of scales with you, it is really difficult to predict. And so, you know, what if you just said to someone, okay, we'll just eat bread at home. So the final picture in my slide there actually shows two pieces of bread from one loaf. And that just explains the variability that we're talking about here. One of them is twice as thick as the other and would potentially need twice as much insulin. So we're really battling against it there. So the second problem with the insulin to carb ratio that we can sometimes face is that is the limitations of our injectable insulins. So with new advancements in technology and production of insulin analogues, we now have insulins that are more sophisticated than ever. Our long-acting insulins are acting longer with very flat profiles. Our short-acting insulins are acting and being cleared from the body quicker than ever. So in other words, our insulins are working at their absolute optimal performance to date. Despite this, we still don't have an insulin that works as fast as naturally produced insulin and cannot match the rate at which glucose enters our blood after eating either a processed carbohydrate such as bread or pasta, or even unprocessed carbs like potato or a banana. We have had to develop ways to increase the intensity of insulin management to improve this, but we will talk about this later. So for the fact that we can never count carbs accurately, sometimes we might be able to, but very rarely, and that we don't have insulin to match the speed of the carbohydrates, the result is post-food or postprandial hypoglycemic excursions. So this postprandial hypoglycemia contributes largely to an elevated HbA1c. So by managing the hypoglycemia at this time of day, we can see improvements in overall glycemic measures. And this is a CGM graph of a high carbohydrate diet. This person's on obviously CGM and an insulin pump and still finding it difficult to manage those post-food highs, even despite using really good technology. So if I have a client who comes to see me for guidance on how to improve their glycemic control, one of the first places I do look is their variability after meals. And so this is their postprandial glucose excursions. And if that's a problem, in most people it will be, there are two ways to manage this problem. One would be to increase the insulin dose or to intensify the insulin regimen. And the second option is actually to visit the nutrition and adjust the person's food intake accordingly. Unfortunately, the knee-jerk reaction of many diabetes healthcare professionals would be to intensify the insulin regimens. When you have limited time in a clinic room, it's really easy to say to someone, hey, you just need to add a unit or two of insulin to lunch or dinner, than to educate them on the impacts of nutrition on glucose levels and spend that extra time discussing the impacts of food. So, of course, increasing the insulin dose is an option, and of course we need to look at the whole picture. But let's look at the evidence, evidence we have to see what happens when we do actually intensify the insulin. So intensification of insulin usually requires an increased insulin dose, and it can also include using insulin timing to try to match the speed of the insulin to match the glucose entering the body. This is sometimes called pre-bolusing. Now, people with type 1 diabetes already make an extra 180 decisions every day in comparison to our non-diabetic fellow humans. So what pre-bolusing means is injecting our insulin 15 to 20 minutes before eating so that the insulin is sitting in the blood ready to work and catch the glucose coming through quickly from the food. And this matches that rise a little bit closer. So this is a good strategy to reduce some of those hypoglycemias after eating, but it is often hit and miss. And if you think about your daily life and having to have an injection 15 to 20 minutes before you eat each meal, the complexity of eating significantly increases and requires careful planning. It doesn't allow for spontaneity in meal times, which is hard, particularly in our busy lives today. I think about my household at dinner. I'm trying to get a child into the bath and to get them fed and ready for bed. So the addition of insulin timing is quite a difficult thing to achieve for most people. So intensification of insulin regimens, and increasing insulin doses, they have actually been shown to result in improved HbA1c, and this has been shown through the Diabetes Control and Complications trial, or the DCCT trial. But at what cost? So the DCCT trial showed us that when we intensify the insulin regimen, we get a 2 to 3-fold increase in hypoglycemia, and we also get a significant increase in weight gain. So why does this happen? High insulin doses increase the risk of hypoglycemia, and we will look at the evidence for this. Not only that, if hypoglycemia is to occur, the only way to correct the overdose of insulin is to consume more sugar to bring the blood glucose back up. This sugar is all stored as excess energy in the body, contributing to weight gain. Not to mention the overshoot and rebound into hyperglycemia, often requiring more insulin to regain control. So this is that picture of the blood glucose roller coaster of a high carbohydrate and intensive insulin therapy. So not only that, high amounts of carbohydrate need high amounts of insulin. Don't forget that insulin is a powerful hormone. It is that can drive obesity, insulin resistance, hypertension, fatty liver, and heart disease, to name a few. People with type 1 diabetes are not immune to the same metabolic complications of hyperinsulinemia as the rest of the population eating a high carbohydrate, low fat diet. In fact, the risks are staggeringly higher. And the obesity the risks are staggeringly higher, and so are the obesity statistics. 50% of the type 1 population is now overweight or obese, compared to only 35 to 40% of the general population. And it's not just the standard guidelines full of carbohydrates that require large doses of insulin to clean up. It's the mentality that people with type 1 diabetes can eat anything and everything they want. Eat what you want and cover it with insulin is deadly advice. So what happens when we look at nutritional management of postprandial hypoglycemia? This is actually where we can manipulate the macronutrient content of a meal to improve the glucose response. And because postprandial hypoglycemia is directly related to the amount of carbohydrate in the meal, we have people who instinctively reduce their carbohydrate intake, such as myself. And this is where the calmness and predictability of a low carbohydrate comes into play. So when fueling the body with protein, healthy fats, low starch vegetables, and small amount of unprocessed carbohydrates, we require smaller amounts of insulin and glucose levels increase at speeds that don't exceed our insulin. So just a little more about me. So when I was first diagnosed, I went through the roller coaster, excuse me, the roller coaster of blood glucose levels. Excuse me. I battled through the ups and downs of trying to deal with a high carbohydrate diet and trying to match my insulin dose to the carbs in my food. I found that I would get it wrong or get it right. Thank you. Oh, that's perfect. Thank you. So I found that I would get it right, and sometimes I would get it wrong. And I've lost my train of thought. Sorry, guys. And really, at the end of the day, I was ending up hyper after a meal. As a result, I instinctively started to lower my carbohydrate intake and lowering my insulin doses to match my foods. And I'll troubleshoot different types of foods and combinations, and I actually taught myself to adjust as I went. And I reduced carbohydrates to be able to give myself that reduced variability after a meal. And I had more predictability and more control over my own body. Through the years, I did rather well. I managed a HbA1c in the mid 6% range, and I was always told how well I was actually doing through my doctors and endocrinologists. And life was a little more balanced, but there was still a struggle of massive highs and massive lows. The lows were the worst. I remember as an intern pharmacist, in the middle of my shift, having to excuse myself from my workplace and downing nearly a whole bottle of Coke on the floor of the staff room just to keep myself upright. It was so exhausting, but I just accepted this as living with type 1. I did some travel for a few years, and when I got back, my HbA1c was around 8%. I was 30 years old, life was getting busier, and I was restarting my career, and I was also studying and starting a family. I didn't have time to be on the floor with a bottle of Coke anymore. I deserved better, and I deserved more than feeling like I was facing failure with each meal. So I started eating foods that gave me good results. I gradually and instinctively reduced my carbohydrate intake, and the stability and predictability just followed. Didn't even realize I was eating a low carb diet until social media pointed out that I did. I'd never tested ketones in my life. And when I checked, they were there mildly. And I've maintained an intake of carbohydrate for the last year or so under 20 grams. Previous to that, I was sitting around 50 grams. And my HbA1c fluctuates from 5.3 to 5.4%. So enough about me. Let's talk about the evidence that we have for low carb diets in type 1. So our very own Jessica Turton has published a systematic review of all of the available evidence of low carb diets in type 1 diabetes and looking at different outcomes. Jess's research drew one major conclusion, which is that we desperately need more research, and Jess is currently working on fixing this problem for us now. What we do know overall is that 6 out of the 9 studies showed a significant improvement in at least one outcome of low carb diets in type 1, such as HbA1c, reduced insulin use, and reduced hypoglycemia, and none of the studies showed any negative outcomes for the low carb diets. So this is showing positive evidence for low carb diets. So since Jess published her study, we saw the publishing of the Type 1 GRIT study. So Type 1 GRIT is a Facebook group of adults and children who follow a low carbohydrate diet to manage their type 1. They specifically follow the protocols of protocols of Dr. Richard Bernstein, and he advocates for low carb intake and a total carb intake of 30 grams per day. Dr. Bernstein is an 86-year-old physician. He lives with type 1 diabetes and he has done since he was 12 years old. He was suffering multiple complications of type 1 and managed to reverse many of them with the low carb diet. So this type 1 GRIT study looked at 316 people, adults and parents of children with type 1. And on average, this group of people had type 1 for 11 years. They had a daily carb intake of 36 grams, and they were following the low carb diet for an average of 2.2 years. So let's have a look at some of the outcomes that we study. And what we routinely monitor for people with type 1 diabetes. So firstly, we have HbA1c, which is a measurement of damage from glucose to the body. It gives us an indication of the average blood glucose for the last 3 months, and it's still the gold standard measurement of glycemic control and the best predictor we have of future risk of micro and macrovascular complications. So the microvascular complications that we're talking about are eye disease, including blindness, kidney disease and failure, and neuropathy causing pain and loss of feeling, most commonly in the feet and hands. And the macrovascular complications include heart disease, heart attack, and stroke. So let's look at populations of T1Ds on a low carbohydrate diet through the type 1 GRIT study. And compare them to the rest of the T1D population. So in our type 1 GRIT study, we found that the average HbA1c was 5.67%. So this is far below the average HbA1c that we saw in the rest of the T1D population. And the T1D Exchange Registry has over 22,000 people. It is in the United States. And the figures from this showed children with an average HbA1c of 7.6 and adults with a HbA1c of 8. So with these statistics, what it actually means is that around 83% of children and 79% of adults are actually at a significant risk of severe complications because that many people are not reaching our standard of 7 and 7.5% for adults and children respectively in terms of HbA1c. The other thing to point out is that in the T1D exchange, this data was actually collected in 2018. And so it also includes a large number of people taking up our latest technology of CGM insulin pumps, so they have the opportunity for optimal control. Something just happened and I lost my clicker. Cool, thanks. So what about here in Australia? So our Australian children appear to be performing much the same with an average HbA1c of 8.3%, with only 27% reaching the target below 7.5. So we're not doing so great. And it was actually Dr. Olivia Remington that brought my attention to this statistic. And in Australia for adults, where we don't have a lot of HbA1c data, but a striking fact is that adults with type 1 are twice as likely to die prematurely for all causes of mortality compared to the rest of our non-diabetic Australians. And more scarily, if you're under 45, the risk of death is 4.5 times that of the rest of the population. And perhaps this is really a reflection of the poor outcomes that we do have as a cohort. So the other part that the other outcome I'd like to look at is severe hypoglycemia. So HbA1c is one thing to look at, but now we do want to look at perhaps looking at time in range or variability. And one of the ways we can measure that is severe hypoglycemia. And really, if we have a reduction in HbA1c, and also the question we ask of low carb diets is, okay, so you're doing really well, but how many hypos are you having? So do people who can achieve good HbA1cs on a low carb diet have lots of hypos? Anecdotal data will show us that no, we don't. The reason is that we use the theory of small numbers. Again, small amounts of carbs need smaller amounts of insulin. Smaller amounts of insulin means a lowered risk of hypoglycemia. Myself in my own life, I rarely have to use glucose to treat a hypoglycemic episode. If I were to drop a little bit low, it's often really slow moving and I have plenty of time to take action. I do have a warning from my CGM, which is usually enough time for me to adjust my pump settings, and I can often avoid the hypo altogether. Mainly the time that I might need to correct is if perhaps during exercise, if I haven't adjusted my insulin pump correctly, if I do more exercise than what I thought. And in those cases, I only ever need about 4 or 6 grams of glucose. So let's look at what the data tells us. So severe hypoglycemia is defined in most studies as hypoglycemia resulting in coma or seizure or requiring hospitalization. So even when we compare our low carb group to the groups with the best technology available in terms of insulin pumps and CGM, there is still more than double risk of severe hypoglycemia in the type 1 population compared to our low carb group. So we can see the type 1 group study showed a 1% rate of severe hypo and 2% with the JDRF CGM trial, which is where we had the best technology, along with that last one of 5%, which shows the sensor augmented pump therapy for A1C reduction still had really quite significant severe hypoglycemia. So what these studies also showed us that the rate of hypoglycemia is directly related to the doses of the fast-acting or food insulin. And what we do know is that the low-carb groups, including the type 1 GRITCH studies, show the insulin usage of around 0.4 units per kilogram per day. And this is what I usually see in terms of the low carbers that I see in my clinic as well. And that's compared to up to 0.7 units per kilogram per day, which is not quite half the amount of insulin in there to control blood sugar levels. So it's directly related to the amount of insulin that we're using. And the area that we see reduced insulin dose is not basal insulin. That will have a slight effect if we go low carb and needs to be slightly adjusted, but it's more significantly the insulin that we use to cover the food. There was another interesting finding as well, that the hypo is actually less likely to occur when we use regular insulin versus the really fast-acting insulins. And regular insulin is one of the insulins that Dr. Bernstein promotes through the his low carb protocol, and is probably used a lot more in the type 1 GRIT study. This is just another study that I found that looked at the rate of hypoglycemia. It was a short-term study. It used 10 people with type 1. They gave them a high carb diet of more than 250 grams for a week. They gave them a washout period, followed by a week on a 50 gram or less carbohydrate diet. Both of the groups had really similar HbA1c estimates of 6.3 and 6.2%. However, it's actually the variability that significantly improved in the low carb group, even for just such a short period of time. So there was an 11% increase in time in range, and importantly, there was a 4.7% reduction in hypos in the low carb group. And obviously there was a lot less time, 5% less time in hypoglycemia. So here we can actually see, again, the correlation between low rates of hypoglycemia directly proportional to the insulin dose for food. So in this group, the basal insulin dose actually didn't change between the groups. However, the bolus or food insulin for the high carb group was 5 times that of the low carb group. So one of the other main concerns about low carb diets for type 1 is the increased production of ketones on such a diet. So there's actually 2 questions being asked here. One is, what is the difference between ketosis and ketoacidosis, which we can answer quite easily. But the other question that I'm more interested in is, does ketosis lead to ketoacidosis? There was a respondent to the type 1 GRIT study that said there should be clinical concern in subsequent trials that patients who have mild starvation ketosis with lower insulin levels could develop diabetic ketoacidosis more rapidly with intercurrent illness and the development of insulin resistance. Yes, I also have this concern, and I am vigilant for risks of DKA in all of my clients with type 1 diabetes. It is a very valid question to ask and a very valid outcome that needs to be continued to be monitored and studied in many different cohorts of people with type 1, including those on high carb diets and low carb diets. So why are we talking about DKA and ketones here? So when we eat a low carb diet, just like anyone else in the population, we will have production of ketones. It is a way that the body switches from using glucose as a primary fuel source to fatty acids and ketone bodies for fuel. This is called ketosis. So in a person without type 1 diabetes, ketosis is an automatically regulated and controlled metabolic state. It shifts the fuel source of the body and primarily the brain from glucose to fat. And it happens when carbohydrate intake is restricted and there's only small amounts of glucose readily available for energy. In these cases, fatty acids provide energy to some of the tissues, while others, like the brain, actually rely on the ketone bodies produced from the breakdown of the fatty acids. So by producing ketone bodies for the brain, the body spares muscle mass and allows the person to remain strong, healthy, active, and alert. Now, the thing that largely controls this mechanism is insulin. Ketone production stimulates insulin secretion in those without type 1, and insulin is required to control the amount of ketones being produced. And the ketones are the molecules which are acidic, and that the amount of acid that's in the body is also controlled by the kidneys. So this is a clear contrast between ketoacidosis. This is a pathological state of the body, and it is known as a serious, and it's also a life-threatening condition. So while it is most commonly seen with people with type 1, it is associated more with a new diagnosis of type 1 or complete or relative omission of insulin injection. So that might be an accidental missing dose, or perhaps an accident such as a pump failure as well, which is another common way. Or it will usually be associated with severe illness or trauma, such as a heart attack or an infection or physical trauma. But what's important to see here is that in all of these cases, we see an absence or a severe deficiency in insulin. And remember, insulin is the key that regulates the mechanism of ketosis. The other important message to highlight here is that no one is advocating for people with type 1 diabetes to stop their insulin on low carb diets. Reduction is not stopping, and we learn how to dose insulin for things like protein and fat appropriately in the absence of carbs. And basal insulin is still an absolute must and a key for people on low carb diets and should never be stopped. So I'm actually going to show you quickly the pathway of ketoacidosis just to explain insulin's role. So when we have an absence or a deficiency of insulin, this means that the cells of the body in type 1 diabetes are starving, and this then turns the body to say, okay, I have a requirement for fuel, I can't get it from glucose, I'm going to look elsewhere. Despite that, it increases the amount of glucagon and cortisol that we release, because the body is still actually looking for glucose because it thinks that there's none there. It's just that it's in abundance in the blood and not getting across the cell. So of course we have glucagon, cortisol, adrenaline, and we're increasing processes called glycogenolysis, releasing glucose from the liver and turning non-glucose substances into glucose. So this ends up in high blood sugar levels, and these people have a lot of urine output and end up dehydrated. These hormones also increase the breakdown of fat, and this is that alternative fuel source that we're talking about. This then increases the amount of fatty acids available, which increases then those ketones because the fatty acids are broken down to ketones, and the ketones are acidic. And this is how we lead to DKA. But what I want to stress is that fundamental lack of insulin or absence of insulin, which is not what we're talking about in a low carb diet. My clicker's gone again. Pete. Sorry, my clicker's gone again. Oh, there it is. Sorry, came up. So what we're talking about here is when we see a new diagnosis, clearly these people are not well. You know, they're not having any exogenous insulin. We also see it commonly in pump failure or someone who's not having their insulin doses. And then the other pathway that we see is people who have a heart attack or trauma or a sickness such as pneumonia. What this does is directly increases the cortisol and adrenaline and bumps up the glucagon. And what this in turn does is show an absolute deficiency of insulin and increases those requirements. Now, the insulin deficiency and this hormone is a constant battle. And if this wins out, this creates a deficiency of insulin. Then the deficiency of insulin creates the increase in these hormones here. So we can see that insulin is key. It's important to also understand that when we talk about DKA, we're talking about very high levels of ketones of over 20 to 30%, 20 to 30 millimoles. And obviously we also see the high blood glucose levels as well. So what does the evidence show us? So looking at the type 1 population, in the type 1 GRIT study, we saw an incidence of DKA of only 1%. And in the general population in large-scale studies, we can see studies of 2.4 up to 9.9%. So there is actually a direct correlation between higher HbA1c levels and incidence of DKA. Again, we're showing in the type 1 GRIT, we're actually seeing quite lower levels. In one of the studies in the adult T1D exchange, we actually saw a 21% incidence of DKA in people with a HbA1c over 10%. So just some conclusions. So, you know, despite substantial developments into insulins and technology, the outcomes for type 1 diabetes is suboptimal. Nutritional research is lacking, and high carb diets are actively promoted for people with type 1 diabetes, despite there being clear evidence of superiority. We need more evidence for low carb diets in type 1. So this is where Jess is going to help us out. And so far the evidence is positive and do show that low carb diets can be considered a safe option for people living with type 1. And lowering carbohydrate intake in type 1 diabetes should be supported by qualified doctors, dietitians, and credentialed diabetes educators. Thank you.